Welcome everybody to the final session of the TIO Congress for 2021. We have the Controversies Part 2. It's going to be a great session talking about left atrial appendage closure versus anticoagulant therapy, and then also talking about left main disease. We have a great panel again: Kendra Grubb, Lars Sundergaard, David Hildick-Smith, and Margaret McEntegart. Welcome back everybody. And I'm really looking forward to this because it's always fun to discuss controversies, certainly amongst friends, but I'm sure we can take different sides and come up with some nuance and some balance. I want to introduce the final poll that I encourage everybody to fill out. We'll show the results later. That is the need for late revascularization relevant in the discussion between CABG and PCI? Simple yes or no. Curious to see thoughts on this because this is an area when we focus so much on mortality and other endpoints that we perhaps ignore late revascularization, or maybe we don't. So let's see what you think about that. I will introduce our first speaker, David Hildick-Smith, who's going to cover this topic of left atrial appendage closure versus novel oral anticoagulants. David, take it away.
Great, thanks very much for that introduction, AJ. I don't know who the guy in the photograph was. That was from about 20 years ago at least. So I'm going to talk about left atrial appendage occlusion versus direct oral anticoagulants and the controversy around that. Is it a controversy? Let's find out. So the received wisdom about left atrial appendage and anticoagulation is that appendage occlusion is equivalent to warfarin in terms of stroke prevention, but is superior to warfarin in terms of bleeding complications. That's clearly intuitively what you would expect, because the bleeding risk carries on every day you take the warfarin. So is that the same or different with DOACs? Of course, the manufacturers would want us to believe that DOACs are hugely superior in every respect, but let's find out if that's the case. What we're going to look at is the evidence around this arena, and then we're going to look at what the common sense thinking is. What does it tell you about this arena? So the evidence is almost exclusively from two trials. So the Prague 17 trial and the Danish propensity matched study. The Prague 17 trial is a very nicely conducted trial. It's beaten a lot of its competitors, as it were, to the area. What they did in this upper box was they took 400 patients with high-risk atrial fibrillation and randomized them to closure or NOAC. And the primary endpoint, as you can see bottom left, showed fundamentally no real difference in follow-up between the two groups over the time taken. So this was a non-inferiority design. What was interesting on the bottom right, if you look at the intention to treat and the per protocol aspects of this study, the confidence intervals are quite wide, and you don't see any particular difference between those two options. The second trial to do this, to have a look at this study, this particular area, was the Danish propensity match study. And this looked at appendage occlusion versus DOACs, taking the Danish registry data. So in other words, what they did was take a huge registry of more than 20,000 patients. You can see on the left-hand screen here, all AF patients in Denmark, 25,000, and they attempted to propensity match them for left atrial appendage occlusion versus direct oral anticoagulation. And the primary outcome was then major bleeding and mortality. And you can see, strikingly, there's a considerable difference between the appendage occlusion and the direct oral anticoagulant groups. And even more so than that, in the bottom right, you see, as was found in the PROTECT-AF study unexpectedly on longer-term follow-up, there's even an all-cause mortality benefit. Now, that may mean that the propensity analysis was not as good as they had hoped, or it may mean, again, that there's a genuine signal that left atrial appendage occlusion offers, for reasons not fully established, a possible mortality advantage. So if we go on to look at whether these results are broadly concordant or not, well, actually they are. They're really much the same as what we saw from the warfarin and left atrial appendage occlusion studies. And is that a surprise to us? Well, frankly, it shouldn't be, because actually, although the manufacturers would like us to think that the DOACs are a completely different animal, actually, much of the problems that are associated with warfarin are seen equally with DOACs. Of course, you can't have an anticoagulation agent which doesn't cause bleeding, and that's where most of the benefit lies. So what are the factors that might be in favor of left atrial appendage occlusion in this controversy? Well, there are four. I'm going to deal with them each briefly in turn. There's procedural factors, there are device-related factors, there are medicinal factors, and there are financial factors. And the main one that we're dealing with in this particular talk is the medicinal factors. Now, firstly, and importantly, procedurally, we're getting a lot better at this procedure. So, PROTECT-AF, people didn't exactly know what they were doing, really, right at the start of this. They only had 2 run-in cases, so the complication rate was high. But now we're getting down to 2.7 in evolution, lower in the Amulet registry, and lower still in the Pinnacle study, very recently reported. So we're getting better at the procedure. Secondly, the device evolution is really helping. So the Amulet has come from the ACP, and the Watchman device has moved on from the initial version to the Flex. And in this arena, with this evolution, it is, of course, survival of the fittest. There are a number of devices that have been trialed or are in trials, and not all of them will survive. The next point is financial, before we get to the medicinal. And this just shows that, yes, of course, there's an upfront cost to appendage occlusion, but afterwards, if the patient lives long enough, and this is why the ideal patients for left atrial appendage occlusion are actually the younger patients, not the patients who are within 2 or 3 years of the end of their life. There's an upfront cost, but at some stage, the cost evens out. And in fact, the appendage occlusion becomes cheaper. Now, the final and most important point is the medicinal one. Roughly 50% of patients who should be anticoagulated are anticoagulated, and there are so many different reasons for this. It can be that the patient doesn't want it. They don't like the idea of bleeding. It's quite scary. It may be that the doctor thinks they're at too high risk of falls or other complications. It may be because of contraindications, perceived bleeding risks, side effects that they've had from the agents. So lots of patients who should be on anticoagulants aren't. And here's a key slide, because the arguments really remain the same for DOACs as they do for warfarin, because the discontinuation rate, when you look at it, compared with warfarin, is broadly the same. Yes, patients don't like having the blood tests for warfarin, but that's not actually what drives them to stop the medicine. It's the bleeding or the risk of bleeding or the side effects. And actually, if you look at the Danish study, the propensity matched analysis, a huge proportion of these patients had actually stopped their DOAC within 2 years. So 60%. So 60% of them are unprotected from the risk of stroke. And by comparison, of course, you can't discontinue your left atrial appendage occluder. So there is, of course, huge interest from this. And actually, of course, as you'd expect, this is largely from the manufacturers of the devices rather than from the manufacturers of the drugs. Here we have the Catalyst study, 2,500, Closure AF, 1,500, Champion AF, 3,000. So these 5 studies together are about 6,000 patients who are going into appendage occlusion versus DOAC studies. And the reason that they're going into these studies and the reason that the companies are putting the money in for these studies is that the companies know, and the doctors running the studies know, that fundamentally there isn't a massive difference between the DOACs and warfarin apart from the convenience. And these trials are being done because they know that they're going to win. Thank you.
That was a great ending. Thanks so much for that overview. And we have a bunch of time for discussion because this is definitely controversial. So maybe I'll just start by asking some questions about first, learning curve. So this requires a transeptal. The devices have iterated over time. And Lars can make it look easy. But it's not, someone would argue this is not an easy procedure. So how do we deal with that? Because certainly here in the United States, we have direct marketing to individual consumers. And then we have this issue of learning curve and safety and can you scale the results? So maybe, Lars, you want to start with that? How do we deal with that situation?
Yeah, well, first of all, I think this is, as you said, it looks like a simple procedure, but there is certainly a risk both with the transeptal puncture to move around in the left atrium with air embolism, to perforate the wall of the thin wall of the left atrial appendage, to have devices which is embolizing, to have device-related thrombosis. So I think we need to be respectful about this procedure because it's a procedure which is done as a prophylactic procedure. So, and again, I think everyone needs to have a learning curve to do it. And I also think we had the discussion about pre-procedural planning. I'm a strong favorite of using CT scan up front to really have a better understanding of the anatomy and try to make the procedure as predictable and safe as possible.
Maybe I'll ask Kendra, you're in there, so how variable is this anatomy really? Does it concern you when we look at devices like this? Are there other approaches, surgical approaches? What are your thoughts on this?
Well, my thoughts are that if you can eliminate atrial fibrillation, you should. And if we can come up with ways to reliably do that are low risk, I'm in favor of that. Surgically, we find that post-op atrial fibrillation is such a nemesis. And if I could ligate everyone's appendage just to eliminate it, even if I was doing a routine CABG, I would say that would be helpful. So I do think that these devices are needed. I think that we still are in a phase where we need to be critical of who we're implanting, but there's tremendous benefit.
And is the atrial anatomy that variable that you've posed? Do you think this is a problem for these types of technologies that go in, or is it something that's easily overcome as a surgeon? I'll ask David next.
The anatomy certainly is variable. But I think with modern imaging, you are going into the procedure understanding what you're up against. I mean, surgically, we're going to address these with clips from the outside or oversew the ostium from the inside. And so we have some advantages in that regard. But percutaneous devices, I think, very much could be designed for the different anatomies. And especially if the operator is entering the procedure knowing that anatomy ahead of time, I think that you can navigate a lot of that.
Great. So, David, tell us your thoughts on that. You mentioned the evolution with the W, which is cool and cute. But tell us, do you feel that it still needs to be iterated, or are we pretty good right now with what we have?
Oh no, it definitely still needs to be iterated. I mean, the ideal thing with this procedure is that it gets to a position where the risk from the procedure is less than 1%. Now, if we get to that position, then this is a procedure that can also be done in the end when you're in the left atrium for some other reason. And that does open the way for this being done during an ablation, during a paravalvular leak closure, with an ASD closure or things like that. And I think that will be the way ultimately it's done. But we have to get to the position where the devices are less thrombogenic, more completely occlusive, with no risk of falling out, no risk, well, almost no risk of causing damage or complications in the position. And I'd also just like to point out that although I have, of course, absolute respect for Lars's approach, which is to know about these things in advance, we do the opposite, which is that we don't do any imaging and we put the patients on the table to do the appendage occluder. And because of the versatility of the devices and the range of sizes now, the proportion of cases in which we have to take the patient off the table because we have not got the right size or there's thrombus unexpectedly is 2%. So I think, it's moving towards a streamlined procedure which should have a really low risk associated with it.
Margaret, I'm going to ask you a little bit about the patient perspective on this. Lars, do you want to say something? Go ahead.
I'm just saying that don't try to extrapolate what the world champions can do. It works fine in Dave's hand because he's a very skilled, very experienced operator. But if you want to broaden this therapy out to many, many institutions, I mean, it really needs to be a safe one. And what works for Dave does not necessarily work in less experienced sites.
That's a great point. Margaret, so coming to you, the patient perspective on this. There's interesting slides shown both with NOACs and warfarin, and we know about time in the therapeutic range, and we also see patients complaining all the time of bleeding complications, that sort of thing. I view this almost as there are people who get really academic and they look at the trial data and they say there's not good rigorous trials and that sort of thing. But if you look at it from the patient perspective, one could indisputably say that if you could reduce anticoagulation, that might be helpful. How do you titrate those things together if you're discussing with your colleagues or if you're your mom or grandma or something like that? Because there's truth in both, actually, I think.
Yeah, I think this is an area that really highlights the importance of the patient participating in the decision-making about their care. And I think it's kind of there's some parallels here with angina, isn't there, in PCI versus optimizing medical therapy and patients not tolerating or wanting to take multiple medications. And we all know that as physicians, we dramatically underestimate the compliance issues with medical therapy. And David really nicely illustrated that in this area. So I think it's really important around about this subject, as I do as well with coronary revascularization, that you can take into consideration how the patient feels about the options. It's not all about just about whether you can get mortality or MI benefit. A lot of it's about the patient's quality of life and their choice of whether they want to have to take medication every day. So I feel very strongly about that in all areas of interventional cardiology, that the patient should be able to choose whether they want to take medical therapy or they'd rather have a procedure done to correct the problem if that procedure is safe and efficient. And I think that one of the interesting things from the data David showed was the Danish registry data. And I was wanting to ask David and the rest of the panel, how much do you think the advantage seen in the Danish registry was due to that DOAC discontinuation rate that you saw, David, in that last graph that you showed? I think that really highlights this issue about patient choice.
Well, absolutely. And I mean, as I tried to suggest there, you can't discontinue your left atrial appendage occluder once it's in, but you can discontinue your medicine, and you can't do anything about it if patients decide, oh, I don't want to take that medicine anymore. Well, you can't you can't make them. They have a rational, reasonable reason for deciding I don't want to take it anymore, so I'll take my risks instead. Whereas with the appendage occluder, it's a one-off procedure, done once, finished, should protect them for the rest of their life from embolization of thrombotic contents from within the appendage. So it should be a really, really attractive therapy. And I think as we just iterate the devices and iterate the procedural aspects and the skills of the operators, it's going to become a really, really commonly done procedure.
Lars, I'm going to ask you a question about the issue of ascertainment of stroke and attributing it to the left atrial appendage, because especially as patients get elderly, the left atrial appendage is one reason why they could have a stroke, but there are other reasons as well. And some have advocated maybe having neurologists see these people to try to determine to what extent it was the AFib versus, just atherosclerotic disease or carotid disease or other things. And others have actually advocated maybe a combined approach of a low-dose anticoagulant to reduce bleeding plus LAA occlusion. How do you parse through all that? What do we need to do to figure this out on a patient level and also with studies?
Yeah, first of all, I think this is a great comment, and to answer it, we need studies to see it. Probably going to see it just like for the PFO closure, that we thought that the PFO is a reason for the cryptogenic stroke in some of these patients, and we closed the PFO, and then we could see, despite it may not be the reason for all of these patients, the net sum of it was actually positive in favor of PFO closure. But again, I think it's a very simple approach to see that it's a PFO for all these patients where you cannot find other reasons. And probably the same for the patients here with AFib, that if you just close the appendage, it may not actually protect the patient for a stroke, because we also know that these clots can also form outside the left atrial appendage. But again, we need certainly more evidence. Just one comment to what you were saying, Margaret, about the Danish study compared to those trials which is running now. I think you're not going to see the same benefit from the Catalyst and the Champion trial, because those patients who are going to be included in those are patients who are on DOAC, patients who can actually tolerate it. So you don't have the patient who's dropping out down the line. So I think that's going to be a much more challenging trial to actually at least to show superiority. It may be non-inferior, but it's not going to see the same strong signal as you saw for the Danish propensity match study.
But I think we're probably going to see the results. I mean, if we're going to have a guess, we're going to see the results that we have the same outcomes for stroke, ischemic stroke that is, but we have continued risks of bleeding with the anticoagulant medication, because of course you can't get away from that. Take an anticoagulant, you're going to bleed.
Yeah, notwithstanding the differences you mentioned about selection of people who can tolerate, it's still an important study to do, because there are still people out there who are not convinced that the reduction of ischemic stroke is commensurate with what you would achieve with a NOAC, and that's the exact reason to randomize, to show exactly that. I think it's pretty important to be able to enroll, and I'm glad the studies are being done. Kendra, tell us a little bit about, I know you talked a little about clipping the atrial appendage, the AtriClip device, which we're seeing. Is this something that should be only done in part of a concomitant surgery? Or I know there's some surgeons who actually will offer this as an initial therapy, but to me that seems like a lot rather than doing a percutaneous procedure. What are your thoughts on that as a whole?
Well, yes, I think that doing a sternotomy to put on an AtriClip is a big operation and probably a little bit overboard. But there is a thoracoscopic approach. They have a thoracoscopic option, which may be a smaller incision to achieve the same goal. But I think from a surgeon standpoint, again, it's treatment of the disease, and whether that's totally percutaneously, thoracoscopically, or as a concomitant procedure, I think we do need to be addressing atrial fibrillation and the appendage more frequently.
I think important points. The challenge sometimes, though, is that some of these folks that have post-op AFib, they get anticoagulated briefly, they never have it again until much, much later in their life. And so should we prophylactically close the appendage or not is an open question for sure. Let's talk a little bit about device thrombosis just briefly. How big a problem is this? What strategies are folks using for this? Anyone who wants to weigh in on that one, because it certainly sounds scary for a prophylactic procedure, as you mentioned, so we should talk about it a little bit.
Absolutely, and it sounds scary because it is scary. You know, there is no point doing a procedure where your incidence of finding thrombus in the appendage is around 4%. If you then put a device at the front of the appendage, which has a 4% thrombus rate associated with it. So, you know, it's absolutely crucial that the devices themselves change over time such that the device-related thrombus rate goes down to lower than 1%. It has to go lower than that. Otherwise, quite often, you won't necessarily be doing an individual patient a good service. So this is an absolutely critical area for improvement. Part of that is stuff which Lars's colleague, Jens Erik Nielsen Kudst, has particularly shown about having the lid of the amulet device, for example, right on the pulmonary vein ridge. If you can get that, then you have a much lower instance of device-related thrombus. And it's already very low with the amulet, with the lid occluding the appendage and excluding it from the circulation. So I think, you know, changes in design of device, thrombus-resistant materials, etc., they're going to be really crucial as we go on with this therapy.
Lars, any comments on that?
Yeah, I fully agree. And
How
we
about,
need to
yeah, go ahead.
we need to understand what's causing these thrombosis and try to choose a device which in a specific patient is going to have the lowest risk. And as Dave was just saying, that if you seeing for these low disc devices, if the disc can actually cover the entrance, the orifice, it's going to reduce the risk of device-related thrombosis. I think we used to think this is a smooth wall entrance, so as long as you have covered the triangulation of the left atrial appendage, there would be no risk, but that's not the case. And also, let's say now we're talking about DOAC. It may be wise for these patients who can actually tolerate DOAC with a low bleeding risk in the future, if you do device closure of the left atrial appendage, keep the patient maybe on DOAC for a couple of months until it's endothelium overgrown, and then disconnect the DOAC.
Yeah, I think the other thing too is there's thrombosis. Go ahead, Dave.
I'm sorry, I interrupted you. No, just to say, you know, with the DOACs, you could, for example, have a quarter dose of whichever one is your drug of choice, or possibly a maximum of a half dose. And maybe this would be a really good compromise. You get the appendage occluder, you don't get the device-related thrombus, but also you don't bleed. And there are trials to be done in that area, absolutely.
Yeah. It certainly needs to be looked into. And I think the other part, too, is that there is sometimes thrombosis, and then there are these indeterminate CT or echo findings that are sort of this gray area that sometimes folks are not sure how to manage. And those probably need some elucidation as well. Margaret, were you going to say something?
No.
Oh, okay, I saw you raise your hand. Okay. All right. Any other burning questions on LAA closure versus NOACs? It's certainly an area of active interest in the field. I think there was also some debate in the prior session about whether the right way to do it is CT versus not. And then similarly, within the procedure itself, can we do this with ICE? Can we do this with TEE? Are we required to do one versus the other? And there's certain people who will swear by an ICE-based approach, and there are other people who will swear by a TEE-based approach. So there's, in addition to device iteration over time, there's also clearly going to be technique iteration as well, which makes it a little bit more challenging to interpret data from randomized trials and otherwise, which might have used prior versions. David, what was your thoughts on that?
Yes, no, I was going to say, actually, the pandemic, interestingly, I mean, it's done almost nothing good at all. But a tiny, tiny good thing it did was get rid of anesthesia and TOE for us, because it was just too impossible. You know, you have an anesthetic, then everybody has to clear out the room for an hour, and the patient has to have 1 million tests and a CT and all this kind of stuff. So we said, okay, fine, that's great. we're friends, but goodbye. And so we switched immediately to intracardiac echo, and we haven't looked back. I think Lars is right that it's sensible, ideally to do a CT scan to know what you're doing with, just in case you get a modest ICE image. But certainly, again, looking to streamline this procedure, I think intracardiac echo or modified types of TOE or nasal probes which don't require anesthesia is going to be the way forward.
All right, very interesting. Any final thoughts from anybody, or I think we can move on to left main disease, another very controversial topic. For me, this was a great summary of the various options for patients. I think we have to be patient-centric, but also look critically at ourselves about how well we're doing these procedures. Are we qualified to doing these procedures? And I think that's a theme that we're going to see expressed when we talk about left main disease as well. So thanks for that discussion, and let's move on to Kendra, who will give us an overview.
Well, thank you, Ajay, for the opportunity to start discussing treatment of left main disease, PCI versus CABG. I will say that my only disclosure in this regard is that Ajay did teach me how to do PCI, so I may be a little biased. And when Ajay and I look at this image, we may be seeing the same thing, and we may both say, wow, that's bad, but we're definitely looking at it from different vantage points. From an interventional cardiology standpoint, we're looking at what's the syntax score and immediately trying to come up with strategies how to best treat this lesion. But from a surgeon standpoint, I'm actually looking beyond the lesion. I'm looking for targets. And in this particular case, this is a great operative candidate. But what do the trials show us? And the two main trials that help guide us are NOBLE and EXCEL. And both trials were about unprotected left main disease with some slight differences. The NOBLE included low, intermediate, and high syntax scores, where the EXCEL trial excluded those high syntax scores. Both were complete revascularization with CABG versus PCI. But the primary endpoints were also slightly different. Death, non-procedural MI, repeat revascularization or stroke for NOBLE, and death, stroke, or myocardial infarction, including periprocedural for EXCEL. And those subtle differences may be the reason that we are having this controversy at all. And the results at 5 years, NOBLE did not meet its non-inferiority endpoint, but EXCEL did. In terms of long-term mortality after left main disease, there really hasn't been demonstrated much of a difference, with the EXCEL trial being an exception with slightly higher mortality in the PCI group at 5 years. Demonstrated here, looking across multiple trials, not necessarily significant differences when it comes to outcomes between PCI versus CABG. PCI slightly better in regard to stroke, revascularization, slightly better for CABG, and risk of MI, slightly better for CABG. The European guidelines have left main disease for low syntax score, class 1 for CABG or PCI, but that's the only class 1 indication for PCI in left main disease. In the US, CABG across the board, however, PCI, a 2A indication for low syntax score of 22 or less in the left main for left main disease, and 2B for less than 33 syntax score. So what about this EXCEL controversy? The authors concluded in patients with left main coronary disease of low or intermediate anatomical risk, there is no significant difference between PCI and CABG. And remember, this is just low and intermediate risk, and this was no significant difference for their primary endpoint. How confidently can we accept this conclusion? The death rate at 5 years was actually 3.1% higher with PCI, but they claim no difference because the composite endpoint didn't differ significantly. The European guidelines, PCI and CABG, both class 1 for left main, but only in low syntax score. And in the US, as mentioned, PCI remains class 2A. Well, here's the issue and the nighttime news that came out on the BBC. There's a slight disagreement in the definitions. How do we define peri-procedural MI? And I'll also question whether or not it's necessarily significant. And does this give us a PCI bias? If peri-procedural MI is defined by the SKY definition, well, then 3.6% for PCI versus 6.1. And this is a clinically relevant MI with large CKMB elevation or high troponin. If you instead use the universal definition, then peri-procedural MI is 4% for PCI versus 2.2% for CABG. But this is not reported in the initial analysis. In addition, if you use the universal definition, then there are fewer composite outcome events at 3 and 5 years after CABG versus PCI. So all-cause mortality higher for PCI versus CABG, but no difference in mortality is what was reported. And as a result, EACTS withdrew support for the European guidelines for low-risk left main disease. Well, what about the rebuttal? The choice of the SKY definition. This is the best available evidence linking biomarker abnormalities to subsequent mortality in large clinical trials. It does avoid ascertainment bias and uses the same criteria for PCI and CABG and avoids counting small events that may have no clinical impact. The universal definition also could not be presented due to missing troponin data in the post-CABG patients. Also noted, the Excel trial was not designed nor powered to assess differences in mortality, and no difference in 10-year mortality was seen with the recent syntax 10-year data. So again, how do we reconcile this data? Is procedural MI an important endpoint to determine comparative effectiveness of left main PCI versus CABG? Noble didn't use this data. In left main PCI versus CABG, you have two very, very different procedures. As mentioned from that first picture, we're seeing it from different vantage points. For PCI, this is less invasive, less stroke, less atrial fibrillation, and faster recovery. For CABG, possibly more durable, fewer adverse events past 1 year. And so we're not necessarily comparing two similar outcomes for the patient. So the heart team discussion ends up being critical. And shared decision-making with the patient and their individual anatomy should remain the tiebreaker. So I leave you with this. Here's a left main case. What's the best treatment here? Do we refer for CABG? Do we refer for PCI? Or is this best treated with medical management? Thank you.
Thanks so much, Kendra, for that. I think you really summarized succinctly, some of the framing of where things are. Controversies, of the he said, she said part aside, I think that even without that, left main disease can be somewhat controversial, but at the same time, at many of our centers, it seems to be less controversial because, we certainly, even after the 3-year data of Excel, didn't really change our practice because we saw the fact that the MI curves seemed to be separating, at least in favor of surgery. And then at 5 years, that was just corroborated, and that could have been predictable as well. So let me start, Margaret, with you. Tell us what you think the ideal way clinically to approach somebody with left main disease is. putting together all the different subspecialties that might inform that care?
Yeah, so I think this comes back to the kind of earlier discussion around the patient perspective and informing your patient. So I feel very strongly in this field that once you've got your diagnostic information, that you should be working out objective outcome data for your specific patient in front of you, and then going down and sitting with that patient and going through all the pros and cons of the different approaches. And if the patient is capable and wishes to allow the patient to make a choice, with knowledge of what they're entering into with the outcome data that we have. So I think the other important point to make here is patients have a hierarchy of priorities of endpoints. We have a composite endpoint of things which the patient, if you go to a patient and you say to them, what's more important to you? Is it whether you're dead or whether you have a stroke or whether you have an MI or you have a repeat revascularization over the next 5 years? Patients are very specific that hierarchy is death, stroke, MI, repeat revascularization. So I think we can academically argue about the nuances of it, but I think from a patient perspective, we should be sitting down, giving them all the information and then allowing them to make that choice if it's possible for them to do so. I think a couple other important things I think to point out are that firstly, the deaths in the Excel were non-cardiac deaths, and there's arguments about what the etiology of that was, but obviously chance statistically is a big factor in that. And the other thing is in everyday practice, and certainly in our practice here, a lot of our left main cases are patients who are high surgical risk or surgical turn down. They make up the large. We do a lot of left main PCI, but most of it is in patients who aren't fit enough to have surgery for whatever reason. I think really importantly is about everything we do is going to the patient with all the information, and if the patient can, with their family, let them make a choice about what's important to them.
Those are great points. David, do you think that PCI is a good alternative to CABG in most patients, some patients? Where do you see that fitting in?
Well, it's tricky, and I was interested that Kendra grasped the hot potato straight on. But I think, if you look at surgery versus PCI for left main stem stenoses, I think there isn't much doubt that if the treatment options were comparable, you'd actually choose surgery for most of them. Unfortunately, the patients have to have surgery to get those results. So those long-term benefits are things which often, as Margaret very beautifully just expressed there, not really the things that are bothering the patient. The patient thinks, who's going to feed my cat? How am I going to look after my wife if I've got a sternotomy? And you have to give them the information, but you then have to respect their decision. And if they say, look, the most important thing to me is that I get back to what I'm doing as quickly as possible. I'm not too bothered about maybe I have to have a repeat revascularization one day. I desperately don't want to have a stroke. And you have to respect that. So very commonly patients are choosing PCI, not always with the best decision-making process, but just thinking, yes, I will be able to have that and return to my life the way I want it, the way I need it, with the things that are important to me. So, I think it's increasingly patients are choosing PCI, and the results are broadly comparable in the medium term.
I think that was a great way you phrased that. We certainly have seen this more or acutely as well in the pandemic with limited hospital resources or patients not wanting to stay in the hospital. But certainly beyond that too, the way you expressed that in terms of the data, but yet people have to have surgery, I think it's a very practical way of thinking about it. Kendra, I'll come back to you a little bit on some of this controversial stuff. So the periprocedural MI, and I think it would be good to have a discussion about this as a whole. Periprocedural MI is not something that we routinely ascertain after a PCI procedure or a CABG procedure for that matter. But in clinical trials, they have been ascertained, and I think you nicely stated you try to have a uniform decision or a uniform definition that can be associated with outcomes. But how do you look at that, that as a whole? And that probably was what caused a fair amount, irrespective of the universal definition or other definitions, even from the beginning at 3 years, it looked like the late MIs were favoring surgery, but the reason that the playing field looked even was because it was imbalanced at baseline. Is that a fair assessment, Kendra? What do you think about that?
I think what you, the way you summarized it is a fair assessment. I actually get pretty upset when somebody checks a troponin on one of my CABG patients who has no ST elevations and no chest pain during their postoperative period. I almost expect their troponin to be elevated just because of the insult that I've done. And so I think that we have to be careful with peri-procedural MI being something that we're measuring just on biomarkers.
Yeah, I mean, to be fair, that it's not purely. Yeah, go ahead, Margaret. Go ahead.
I was going to say, I think this is quite an interesting topic, and I have to say that, you know, counter to some of my colleagues' opinions as well, and as Kendra's, I actually think we should be going looking for peri-procedural injury, because if we're going to refine what we do as interventional cardiologists and surgeons going forward, we should be trying to avoid peri-procedural injury, because that's why patients get peri-procedural complications and issues like AF and such like. So, you know, for instance, in the field of CTO PCI, there's been a lot of discussion around about this recently, and the CTO ARC has opted for a kind of SCAI type definition. And I have to say, I don't agree with that. I think we should be looking for universal definition MIs and working out how we reduce causing these events if we're going to try and refine and get better at what we do. So I think we should be flipping the thing around and actually really focusing in on causing injury to the myocardium and how we prevent that, both from a surgical and from an interventional point of view.
I think you're really right, Margaret. But if I could just make the point that I think in clinical trials, it's really, really important to do that and to ascertain the data and understand what we've done. But I'm going to side totally with Kendra on the issue of people randomly measuring troponin and ending up, and not just because it upsets my ego, although it probably does, but because sometimes they then go and say to the patient, "Oh, you've had a heart attack, did you know?" And that's incredibly damaging to the patient after what the doctor has told them was a successful procedure. So I really don't think having wide access to everybody measuring a troponin and then telling the patient something because of that is terribly helpful. And I like to restrict it to the trial setting.
Well, if you're going to actually practice...
argue, though... Yeah, go ahead, Margaret.
I was going to say, but you shouldn't be doing that. You should be collecting all the other data, ECG change, you know, obviously not in the surgical setting, but in the interventional setting, whether the patients had sustained chest pain, is there new wall motion abnormality on imaging? So, you know, troponinitis or myocardial injury, we shouldn't be telling patients about that, but we should be looking for infarcts with other evidence of ischemic injury. That's what I'm trying to say.
Yeah, so Margaret, I think that's an important distinction. And to come back to Kendra's point a little bit about even the SCAI definition is that there are biomarker-based cutoffs, but then there are also with adjunctive EKG, with adjunctive echo, somebody who has protracted chest pain and ST depression, those are clinically relevant findings. And I think we would all agree that those are things that you want to be aware of. We're not saying to blow those off. One of the challenges that's happening now, though, with especially the high sensitivity assays, is that in our clinical trials, we're starting to see the overall clinical endpoint is completely dominated by these biomarker elevations, and you miss the signal that you're trying to look at, whether that's a late restenosis for a drug-eluting stent, whether that's other endpoints, because it's all dominated by these what are called MIs, but probably have no relevance whatsoever to the patient. Frankly, we see this in the ischemia trial too. So in the ischemia trial, biomarkers were ascertained and MIs were adjudicated, but we can all see that whatever strategy of revascularization was undertaken in the invasive arm, it was that beginning offset that then negated the late MI benefits that were actually observed within the trial itself. I'm not saying that we should blow off those early events. Certainly if they're clinically relevant, they're important, but we may be kind of losing the forest for the trees by trying to routinely ascertain it when we only have assays like high sensitivity troponin, and we see this in many trial sites now, they can't even do CKs anymore. So they're ascertaining high sensitivity troponin, and I can guarantee you that maybe not Kendra, but if I were doing cardiothoracic surgery, I would have a high sensitivity troponin positive after doing the surgery because it would cause me that much stress, and it's that easy to get that biomarker. Obviously, that's a facetious statement. Let's talk a little bit about mortality as a whole. Meta-analyses have maybe shown that there's really no difference between surgery and PCI, but yet we saw this in Excel. Margaret, you spoke to the fact that it's maybe play of chance, maybe it's non-cardiac. In the surgical community, Kendra, a lot of focus has been placed upon that. Is it because of a desire to trash Excel, or is it real, or do we not know?
Well, I think that surgeons take the death part of a trial very, very seriously. And even though the trial was not designed to have that be the primary endpoint, that was something that you could definitely hang your hat on, because everyone will say that death is a definitive outcome. But you're right, it was driven by non-cardiac mortality, and we have to keep that in perspective.
David, what do you think? Does it really matter for patients?
You mean whether the death is cardiac or non-cardiac? I think it doesn't. I think, as I said before, I think it's only a minority of patients who, when you go and talk to them, actually say, well, which treatment will help me live longer, doctor? That's actually quite an unusual comment from a patient. Having said that, a functioning lemur graft is an absolutely magnificent thing. And it's hard to believe that that doesn't offer some kind of prognostic benefit over many years, because you see them working unbelievably well 20 years later, et cetera, et cetera. So a functioning lemur graft is an incredibly powerful tool, and it would not be surprising if that did have some prognostic influence.
Yeah, and I think it gets back to Margaret's point initially where she mentioned that for all of us that do a lot of left mains, it's typically in the surgical turn-down type population, because if all things are equal and the patient is willing to have surgery, I think maybe not knowing for certain the mortality data, but MI for sure, and then repeat revascularization certainly favors a surgical approach. Margaret, tell us about the late effects. So repeat revascularization favors surgery in Excel and Noble 3 and 5 years. But then those vein grafts start closing down. And then they come to you, and if they don't have you, which most people don't, then oftentimes they get treated medically, and all they have is that magnificent lima that's open, and everything else is CTO, and they may have issues beyond that time period. So what do you think about the repeat revascularization data? Do you think that that's going to change with longer term follow-up?
Yeah, I think so, and I think it's a really important point. And as you mentioned, doing a lot of CTO PCI, we see a very significant volume of that. About over a third of my patients are post-bypass rights and circs that have had vein grafts that have occluded and have returned with very aggressive progression over the years to occlusive disease. And there's lots of data now showing that we get more aggressive progression in these vessels once they've had a vein graft on. So, I think repeat revasc after both PCI and bypass have their different issues. I think there's a kind of unquantifiable effect of the fact that we all certainly intuitively feel that if a patient comes to a non-interventional cardiologist with an NSTEMI or with angina and they've had bypass before, they're much more inclined to manage them medically than they are to refer them for intervention. And I think that protects bypass from repeat revascularization in the studies and in the real world. I think there's definitely a kind of gatekeeper effect there. I would suggest, and often by the time you see somebody who's had bypass surgery before, they're completely maxed out in their medical therapy before they'll turn up for their CTO PCI. I wanted to put a question back to you guys in the States, and certainly in the UK, there's very little hybrid work going on where you get a lima and then you get PCI to your circ and you're right. Has that taken off in the US?
Kendra, what do you think? I'll tell you at our site in a second, but Kendra, go first.
Well, I happen to have two partners who are robotic cardiac surgeons. And so at our institution, there's a tremendous amount of hybrid revascularization done robotically, with a Lima to LAD done robotically and PCI as a stage procedure. And so here it's very prevalent. I would not say that's the norm across the country, but high volume academic centers, you're often going to see this type of strategy.
Yeah, unfortunately, nationally, it's pretty low. There are these pockets of sort of expertise that will be able to do that type of an approach. There was a trial that was started and had to be ended because of lack of enrollment here in the United States. The economics sometimes don't favor it. There are a variety of excuses you can get around it. But it does come back to David's point about how the Lima is great. And many surgeons, if they see, focal-ish disease in the right, will be the first to admit that the vein grafts will be fine, but for a little bit, and then it's going to occlude, and it might just be better to do PCI of it now as opposed to having it occlude and have a CTO. David, what do you think has been your experience, and why is there not good uptake of this?
Yeah, I'm interested to hear that Kendra has, that setup. I mean, in the UK, when that was mooted and there was a clinical trial going to happen, and basically on two grounds, one economic, and the other just patient acceptability, it was really difficult to get people interested in this at all. And so I'd be interested to hear from Kendra how accepting the patients are of this suggestion that you have an operation, and then after your operation, you still have to come back and have some stents. And how often do they say, well, can't I just have a bunch of stents instead?
Well, I think it's all about how the message is delivered. And so when you're going to a robotic surgeon, you're going to get a robotic Lima to LAD. And so I think that the patients that end up going down that pathway not only have their cardiologists bought into the belief that this is a acceptable strategy, but when it's being presented to the patient at the time of their left heart cath, this is just the norm for them. And they're suggesting this is better than a full sternotomy and 3-vessel bypass. And the patient actually ends up getting their PCI the day after. So their total length of stay still ends up shorter than if they had a full sternotomy. They tend to go home on post-op day 3 from the robotic Lima to LAD. Their incision is tiny, and they do very well. So I think the patient's on board, because just as I'm hearing you say that you believe in the Lima to LAD, I think many, many cardiologists do as well.
I think that's a great summary of the how to do it, and it really needs to be done in a programmatic way. Unfortunately, we don't have the studies to back it up, but intuitively it makes sense, and perhaps if it gets done more frequently, then it could be better studied in that way. Can we show the results of the poll that we did before? It'd be nice to sort of see that before we wrap things up. This was a poll on repeat revascularization, and is the need for late revascularization relevant in the discussion? Virtually everybody says yes, which is interesting because, as you know, the trials, some have included that endpoint, some have not included that endpoint. But for patients, you certainly have to discuss that with them, and we know what the data shows there, not just for left main disease, but also for multivessel disease. My feeling is that this has been honestly a great discussion. It's an interventional meeting, but we have people with a variety of experiences, clinical, also technical, what they do. This is a nuanced area. It's certainly not one where it's cut and dry, and nuance is often where the controversy seems to lie, but when you go into the details, you often find that people are saying the same thing once you take the emotion and all of those feelings out of it. So thanks to all of you for a fantastic discussion on left main disease. There's certainly more to come in that regard. There's also technical competence. We have to be able to do the procedure really, really well and reproducibly using imaging, using optimized stent performance, certainly if we're going to even match what could happen in both Excel and Noble to that extent, and what the surgeons are able to do as well. So with that, I think we'll wrap up this day 2 controversy, or part 2 of the controversy session on day 3. Thanks again to everybody. It was a fantastic day, and then we'll have a concluding wrap up as well. Thanks, everybody.
And that was day 3 of TIO already. So time really went by very fast. And I think to highlight day 3, I would say the visionary keynote lecture of Marty Leon was unbelievable. I think the way he illustrated what is ongoing and what is the near future in aortic valve replacement therapy is quite intriguing. I enjoyed the live cases. I think we had a nice illustration of the new kid on the block to treat calcified lesions that has arrived in Europe 2 months ago. I think this one definitely is going to stay, orbital atherectomy. On the other hand, we saw a fascinating LAA closure case from the boys in Rick's Hospitalet, where they did it under local anesthesia and ICE guidance. I think this is a must-do procedure for me, at least in the future. Then the controversies. I think this was new to TIO. I really like the insights and the perspectives that were voiced during those controversies. I think the discussions were quite balanced, but at the end of the day, the conclusion is that the need for scientific rigor and good quality research has not dried up. With that, I think we are coming to the end of TIO 2021. We had 1 day on structural heart interventions, 1 day on coronaries, and then the day of discussions, all mixed with poll questions and live cases. I think also from the poll questions we learn about insights from the audience. We also learn where the field is moving. I think the live cases demonstrate that what we are doing, what we're talking about, really is now and here. I think for imaging, invasive imaging in coronary, that is a must do. I think RJ also mentioned that. I think transcatheter aortic valve replacement is only going to grow. We are moving away from the risk score discussion and going to a more lifetime management discussion. With that said, I would like to thank my co-directors, Holger Thiele, RJ Courtenay, David Hildig-Smith, and of course Kendra Grubb. I would like to thank also Marty Leon for the keynote lecture and the entire faculty for really a stellar edition of TIO 2021. I also would give a shout out to the folks at Radcliffe Cardiology for a massive support. We have been working day and night for quite some time to bring you this product, and I think we became quite successful. I also would like to thank the audiovisual support team. I'd like to thank my team here, my audiovisual boys here in the Thorax Center, my own department of interventional cardiology and cardiology. It is a team effort, and I really enjoy it. Make no mistake, TIO is not a meeting that is pandemic related. I hope that by the end of the summer we all will be out of this pandemic and we'll get back to normal life. But make no mistake, TIO will come back probably at the end, or hopefully at the end of the year, with potentially a focused version, and then next year in 2022 for the 3rd edition of TIO, with hopefully also the same faculty of experts. Thank you very much for staying with us. You've been one of the 14,000 registered, over 14,000 registered folks that participated in TIO 2021. I do look forward to see you next year too. Enjoy the rest of the spring and summertime. Enjoy also as we are moving towards the end of this pandemic. Stay healthy, stay well. I see you down the road. Thank you very much. Goodbye.